Good evening, everyone, and thank you so much for joining this session. And we are going to speak something about which I feel quite strongly about, which is inpatient glucose management, and this is excluding the DK and HHS, which I think most emergency physicians are very comfortable with. We're talking about the other conditions where you need to control the glucose, but it's not exactly a hyperglycemic emergency per se. So why is this topic actually important? Because first of all, diabetics is like super common in this country, and it's going to get even more common as the lifestyle is continuously changing more towards the Western diets and all. So we have clear protocols for things like DK and HHS, but inpatient glucose management has a lot of variation. So when I was an intern, I was very curious about this topic. So I used to go and ask all of these medicine professors. So Professor A will tell me one method. Professor B will tell me a completely different method. Professor C will give me a brand new concept about how to approach this. So there's a lot of, practice variation that is going on. So this can be very confusing for a lot of people, especially those who have not done a lot of insulin adjustments for inpatients when they were an internship or just after internship. But the whole goal of this particular talk is to make sure that people understand that this is actually a very easy thing to do, and most people who are post MBBS or even interns can do this fairly competently if they have the right concepts in place. So before we start, we have to have a few ideas about a few topics. One thing is stress hyperglycemia. So, what do you mean by stress hyperglycemia? This is something that we see in a lot of patients. For example, patient is having sepsis, patient is having pneumonia, cellulitis, and because of the stress of that underlying condition, it leads to hyperglycemia, but not quite tipping the patient into DK or HSS or something. So why does this happen? So basically, because of the underlying trigger, you have increased stress hormones like cortisol, glucagon, adrenaline, and this will lead to hyperglycemia, and eventually it can lead to insulin resistance. So the question is stress hyperglycemia useful to the body, or is it harmful to the body? So should we control this or not? So you have to understand a few things about the possible harms of stress hyperglycemia, possible benefits of it, some of the iatrogenic harms of giving too much insulin, and some of the metabolic side effects of insulin. So is this thing actually useful? Well, actually yes. So if the patients who are having poor perfusion, having increased glucose available to the tissues can be a good thing. It has been shown to actually improve the cardiac function in animal models, and osmotic diuresis, although it is considered to be a bad thing when you come to DK and all, it can actually be a good thing in other types of patients to help reduce the fluid overload. And this is how the concept of this is fairly recent, because you have the SGLT2 inhibitors, which are becoming very popular in patients with CKD, CHF, etc. And it shows that osmotic diuresis is not always a bad thing. It can have its own uses sometimes. But on the flip side, so what are the possible harms of stress hyperglycemia? One thing is that patient is having an increased urine output, and this urine output, although generally people consider an increased urine output to be the most reliable marker of overall tissue perfusion, that might not be the case in the patients who are having, uncontrolled blood sugar levels. And the osmotic diuresis can lead to a degree of hypernatremia as well. So it can actually damage the endothelial calyx of the capillaries, leading to some degree of capillary leak as well, which is not good. And it can actually impair the leukocyte function as well. So what about iatrogenic hypoglycemia? This is another important thing that you have to understand, is that hyperglycemia will not kill people very quickly, but hypoglycemia can. So it can lead to permanent neurological injury and even death if it is like sustained for a prolonged period of time. And what you have to be careful about in the ED is that independent and sedated patients are not going to manifest any symptoms of hypoglycemia that we normally learn in MBBS. And hypoglycemia has been associated with increased mortality in some trials, which we will get into shortly. So there was a study of ED adverse drug events, and they noted that one of the actually the most common culprit for adverse drug events was actually insulin. So whether you consider that as an adverse drug event or whether it is medication error, that is debatable, but it is one of the most common causes of physician induced harm to the patient. So even studies have shown that even moderate hypoglycemia is even so the generally the studies define severe hypoglycemia as levels less than 40 and moderate at something between 40 and 70. Even moderate hypoglycemia can cause harm in patients because it causes autonomic dysfunction, can lead to vasoconstriction, and it can actually activate your leukocytes, leading to a release of inflammatory cytokines. So all of this is probably not good for the patients. There are some metabolic side effects as of prolonged insulin therapy, other than the obvious, effects on glucose. So it can actually suppress something called autophagy, which is actually a beneficial process involved in the recycling of cellular organelles. So this is some of the pathophysiological concept behind stress hypoglycemia, iatrogenic hypoglycemia, and how to actually find the perfect balance between, providing benefit to the patient while minimizing harms. And now we will go into the studies and what are the evidences that we have at our disposal to actually guide us in deciding how we manage blood glucose levels in the inpatient setting. So there are basically five important trials that you will have to know if you are an emergency medicine resident. So there's the Leuven surgical trial, the Leuven medical trial, the bicep trial, and the most important trial of them all is going to be NICE sugar trial in 2009. And the latest trial is the TGC fast trial. And what I would like to know is, like people to know, is that the Leuven surgical trial, the Leuven medical trial, and the TGC fast trial was basically done by the same group, which was basically a single center study in Belgium. So we'll start with the Leuven surgical trial. This was again a single center study done in Belgium, and they recruited a large number of patients, 1,500 odd patients, and these are all surgical ICU patients, and they looked at the benefits of tight glycemic control. That is aiming for a range of 80 to 110 milligrams per deciliter in these kinds of patients. And what they showed that there was actually decreased mortality in these surgical ICU patients if you had a tighter glycemic control. So it actually decreased by half according to their study. So on the back of this particular trial, there was a renewed enthusiasm, let's say, for over aggressive management of inpatient hyperglycemia. So most people thought that there was a mortality benefit to be had if you are aiming for lower and lower glucose targets. But you have to recognize that this trial actually had a lot of weaknesses. First of all, it is a single standard and non-blinded trial. It has a low fragility index. So can somebody tell me what a fragility index is? So can somebody tell me what a fragility index is? I think Prajwal is here. Prajwal, can you try? Do you have any idea what a fragility index is? Okay, it's basically the number of patients who should have a ha, Prajwal?
I'm
Okay.
not sure, sir.
Okay, no issue. So it's basically number of patients in the study who should have a different outcome for the overall outcome of the study to change from positive to negative or negative to positive. So this fragility index is two. So you only need two patients who should have a different outcome for the entire trial to change from positive to negative, and the p value was actually barely significant at 0.04. So that is one thing. And most of these patients were actually cardiac surgery patients. So obviously, this means that we cannot really generalize this to other patient groups. A lot of early TPN was used, which doesn't really apply for most of inpatient care. And it was actually terminated early following interim analysis. And this by itself leads to a lot of bias because Sometimes you have some benefit which is seen early on, but after a while that benefit actually disappears. And this is actually seen in other trials like the adrenal trial, where initially some interim analysis showed benefit, but later on, once the study actually completed, it showed no benefit. So the trial being terminated early is another weakness here. So following their great success with the surgical patient, they decided to transition over to medical patients, and went for the same thing. So a thousand something medical ICU patients, and they again looked at right glycemic control. These are 80 to 100 mg per deciliter, versus conventional goals are around 180 to 200. So the primary endpoint was mortality, which was a negative in this particular trial. But this trial again showed some improved secondary outcomes, so like more rapid weaning from the ventilator and reduced AKI. So again, so some outcomes which may or may not be actually due to chance, because the primary outcome was actually negative. But again, this was a partly positive trial, you can say, for tight glycemic control. Then you have, again, this was done by the same group. So liver surgical trial and liver medical trial were both done by the same group. Then you have the bicep trial, which is done in Germany, which looked at around 500 patients with severe sepsis, and this is actually the reverse, where it was actually terminated early due to increased harm in the tight glycemic control group due to increased hypoglycemia. So that was actually the complete opposite result. And then you come to the big trial, which is actually the nice sugar trial. And this is probably the best trial that we actually have on this particular topic. So it was has a large multi-center RCT, and this actually crossed multiple continents. So it actually involved Australia, New Zealand, as well as North America, 6,000 patients and over 42 institutions. And they included patients that they felt that they were going to have an ICU stay of more than 3 days, basically. They compared tight control of blood glucose between 80 to 100 versus more a liberal group of 140 to 180. And what they showed here was that it actually had more mortality in patients who had tighter control, at least 3% more mortality in the tight control group, the 80 to 100 Wala group. Now, this is a very unusual trial for a couple of reasons. First of all, it is very rare in critical care to actually have large trials, 6,000 patients showing actual differences in mortality. That is number one. Second thing is that generally the treatment groups tend to be doing better. So it is very unusual for a treatment group to actually have increased mortality. So because usually what happens is that when you're conducting a study, the treatment group will generally get more attention, and by default they'll get a little bit more care than usual. So for the treatment group to actually have increased mortality does suggest that does this particular uh, management protocol of tight control actually causes a lot of harm to patients. So there are some weaknesses with this trial also. For example, there was no difference in mortality at 28 days, but it showed a mortality difference at 90 days, which is kind of confusing. So again, there are some critics of this also, but all in all, this is the best trial that we have on this particular topic. And you can see that the increased risk of death is increased not just with severe hypoglycemia, but also with moderate hypoglycemia. You can see on the curves here that even moderate hypoglycemia is having an increased risk of death in across the groups. So now coming to the most later trial, that is the TGC-FAR trial in 2023. This was actually done by the same people who did the initial trials, the liver surgical trials and the liver medical trials. This was basically done by the same group. This time it was a larger RCT. They brought in more number of patients, 9,000 patients. They try to compare an intensive control arm, again 80 to 110, versus a more liberal target about 180 to 215. So, and this time around they found no differences in mortality even amongst the various subgroups. So if you remember, the liver medical trial actually showed some benefit in certain subgroups, for example with the weaning from ventilator and all, but the latest trial has actually shown that there is frankly no benefit in any of the subgroups. So there is something that you have to understand from the literature when it comes to glycemic control and mortality in critically ill patients. So it is kind of different when it comes to patients who are diabetic before they came to the hospital and patients who are never actually diabetic to begin with. In patients who are never diabetic to the begin with, increased glucose levels and increased glucose variability has been associated with the increased mortality. So in non-diabetic patients, increased glucose levels are associated with increased mortality. But in patients who are already diabetic, they have been having increased blood glucose levels for a long time, months, years maybe. In them, increased glucose levels are not associated with increased mortality. So in those patients also, hypoglycemia on the other hand is associated with increased mortality. So this is an important differentiator that you need to understand between patients who are non-diabetic and diabetic at baseline. Now, why would non-diabetic patients start developing significant hyperglycemia? It could be due to a very bad underlying disease, very severe type of sepsis, perhaps very difficult to manage underlying condition that is leading to a large release of stress hormones. That is one theory. Or maybe the patient had some underlying insulin resistance as well that was not noticed beforehand. That there are multiple theories and all, but the basic inference from the literature is that non-diabetics increase glucose, increase mortality. Diabetics increase glucose, not really associated with increased mortality. So ultimately, what do the guidelines say based on the literature that I just described to you? So you have ACP guidelines from 2014, SCCM guidelines from 2024, and the latest ADA guidelines in 2025. ASAP guidelines basically recommends something between ACP guidelines, sorry, recommend something somewhere between 140 to 180 in surgical and medical ICU patients. SCCM basically they are recommend against tight glycemic control, and you can aim for something between 140 to 200. That is what they are saying. ADA, what they're saying is that again 140 to 180 is acceptable, and in patients who are having increased risk of hypoglycemia, for example, your CKD patients, even up to so even up to 250 might be acceptable. So one thing we have to understand is that as per the evidence that we have only proven that 140 to 180 is safer than the tighter control like 80 to 100 and all. We have not really seen if even higher controls are also safe or even safer than what we are recommending right now. We just don't have the evidence as of now to actually makes those kinds of inferences. But these are the guidelines, and generally they are going away from tight glycemic control, and somewhere you can aim for somewhere or less than 200. That is the take-home message from all of these guidelines put together. Now, you have to understand if you are going to adjust insulin for any kind of patient, you have to understand the risk factors for hypoglycemia. And basically, the three big ones you have to remember is one, elderly patients, two, CKD patients, and patients who have had history of hypoglycemia in the past, or patients who are having sugars which are not really very high to begin with. So no history of diabetes or lower A1C levels. So if you're starting insulin in these types of patients, you have to remember that these patients are at a higher risk of hypoglycemia. So if you're adjusting insulin for these patients, you have to be careful and start at slightly lower levels if possible. So do you actually measure an HbA1c in inpatient? As per guidelines, they recommend that if the patient is having persistently elevated glucose levels more than 140 and no A1C has been done in the previous 3 months, it might be worthwhile to actually get an HbA1c done. So why is this actually being recommended is that despite what many people think, a single RBS level gives you very little information about what the overall glycemic control for that particular patient is. Uh, uh, Like, so as you can see in this graph here, if you look at the HbA1c of 6, which is basically pre-diabetic range here, you can have a wide variety of, non-fasting glucose levels. So anywhere from 350, 400 all the way to 100. So you really cannot predict what the underlying glucose control of the particular patient is like just from your random blood sugar levels. So I hope this, whatever I said uh, until now has made sense, because from now on, we are going to again switch and we are going to move in towards insulin pharmacology. And i- if- in order for this to make sense, we are going to discuss a few basic concepts about insulin. I hope this new screen is now visible. If it is visible, just give a thumbs up. So we are going to be discussing here about how to about normal insulin secretion. I hope the screen is now visible. So normally in you and me, our insulin levels is never zero. It is never going to be zero. You always have a little bit amount of insulin in your body, in your bloodstream, even while you are fasting. Now, what happens when you actually take a meal? When you take a meal, your blood sugar levels increases, and this is sensed by your pancreas, which will secrete your insulin. So this will lead to a this will lead to a increase in your insulin levels, a peak of insulin. So normally, what happens is that you have 3 meals per day, so you will have 3 peaks of insulin per day. So what you need to do is that you need two things. One thing is you need a basal insulin and a bolus insulin. Why? Because in order to have adequate control, you want to this normology as far as possible. We want to mimic this normal as far as possible. The whole fundamental for insulin in, in general. So okay, don't know why the video is going off, but anyway. Okay. So we have different types of insulin. So basic 4 classes. We have rapid acting, short acting, intermediate acting, and long acting. So rapid acting and short acting, both of these can be options for your insulin before you patient needs, before the patient has meals. So what you don't do is you don't give bolus insulin if the patient is in NPO. Generally, that is not an ideal strategy. It's basically NPH. They do not have long-acting insulin, so they use intermediate-acting insulin twice daily, which more or less kind of acts like a long-acting insulin. Then you actually have long-acting insulin, which is basically the ideal method of providing a basal insulin, which is a 24-hour peakless insulin like glargine. So rapid acting insulin, all of them are interchangeable basically from a pharmacological point of view. You have Lispro, aspart, and glulicine. Onset within 20 minutes, peaks around 1 hour, and lasts around 5 hours. So compare this to regular insulin, which has an onset of more around 1 hour. The problem with this is that bit of time to act. So this can lead to two problems. It can lead to increase levels of postprandial hyperglycemia and late postprandial hypoglycemia, because your insulin peaks actually are not really matching that well with the increased glucose from the meal intake. So that is one reason why rapid acting insulins are considered better than short acting insulins. But again, there's a cost issue here. So short acting insulin, regular insulin is much cheaper than rapid acting insulin. So basic options that we are having is that for bolus insulin, we are having rapid acting and short acting. Most commonly, you're going to be using for short acting, and for long acting so for bolus insulin, sorry, so for basal insulin, you are having either long acting insulin, or if that is not available, you can try your intermediate acting insulin as well. Okay. Okay. So one thing you have to remember is that regular insulin is the only insulin here that is actually given IV. If you are giving regular insulin IV, it will have a more rapid onset of action, but it is also going to have a shorter duration of action. This is why when you're putting the patient on an insulin infusion for DKA, you always overlap with the basal insulin for a couple of hours before you actually stop the infusion, because IV insulin has a very, very short duration of action. And again, this is why we don't give IV boluses to actually control insulin levels. Now, coming to strategies of giving insulin in patients. So you can have an insulin infusion strategy, a basal bolus strategy, or a correctional insulin only strategy. That is an isolated sliding scale strategy. So basically, these are the three options that you have. And if you understand what I told you earlier, you will understand that the most physiological of the three options are going to be your basal bolus strategy. But there are some situations where the other two strategies might be a better choice. So, how do you actually choose between these strategies? When do you actually choose for an infusion outside of DKHHS? So if you have a severely elevated glucose level, unrecordable RBS, so that might be a good reason to start the patient on an infusion. Hyperglycemia, that is actually refractory to a basal bolus regimen, then you can start thinking about starting the patient on a continuous infusion. If the patient is having impaired perfusion to the peripheries, for example, patient is in shock, then an infusion is going to be better than giving something sub-Q, that because the sub-Q route is probably not going to be absorbed that well. So I hope that this is making sense. Now coming to basal bolus, this is the most commonly used strategy, and this is always going to be the preferred strategy in type 1 diabetics. You have to remember one very, very important concept is that in type 1 diabetics, you you always have to give a basal insulin. If you do not give a basal insulin to a type 1 diabetic, they will go into decay. So in inpatient, they will go into decay if you do not give them basal insulin. So don't give them only regular insulin. Don't give them only regular insulin, that you'll get into trouble with that. If the patient was initially tried on a sliding scale and was not getting control, you can you can upgrade them to a basal bolus regimen. And basal bolus regimen can also be used once you transition the patient off an insulin infusion. Now, finally, is the sliding scale only option. This may be used in patients who have mild diabetes and who are not actually on insulin before they got admitted to the hospital. In that cases, it might be appropriate to actually go for a isolated sliding scale option, but this is not a recommended strategy in most patients because it is not physiological. So, what are the basic building blocks of a sub-Q insulin strategy? So, you need three things. Actually, you need actually two things, but for in the literature, it is described as three things. So, for basal bolus, you need basal insulin and nutritional insulin and the correctional insulin. So we'll discuss what all of these actually mean. So basal insulin is what we actually describe, the long-acting insulin. So what we usually do, I'll just switch it back to the board here. So again, what we actually do is that for in order to con- Okay, so what we actually do is the first step in calculating a basal bolus regimen is to calculate total daily insulin requirement. And this in most patients is going to be zero point 0.5 unit per kg. What does this mean? This is the total daily TDD is basically the amount of insulin that the patient needs in 24 hours. Amount of insulin the patient needs in 24 hours. So it is going to be zero point 0.5 unit per kg in most patients, but it will be reduced in some patients to zero point 0.3 unit per kg. For example, patients who are more than 70 years of age, geriatric age group, or patient is having CKD, creat of more than 1.5, or the patient's initial blood sugars are not really that high to begin with. You will start off with a lower TDD calculation. So let's take an example here. So you have a 60 kg patient, so that will give you around 30 units of insulin per day. So you will split this into 15 units. You will give it as basal, and 15 units you will give it as bolus. So now the basal can either be given all at once, HS as glargine, or it can be given as split into two as NPH. Both, both of these methods are used, although it is generally recommended to use glargine only. For bolus, so it will be divided into three. So you have 5, 5, 5, and generally we like to use even numbers. So you can convert this into 4, 4, 4. So this is given pre-meals. This is given pre-meals. So for 4 units pre-meals. So this is this is your nutritional insulin. But the thing is that this bolus insulin, it is not fixed. So bolus insulin is always going to be a little bit dynamic based on patient's pre-meal RBS values. Based on your pre-meal RBS values, you will adjust plus something 2 plus 2 plus 4. We'll get into that shortly. So you will adjust your uh, calculated bolus dose. Your calculated bolus dose was 4, and you will add 2, 4, etc. depending on what your pre pre-meal RBS was. So this is what is referred to as your correctional insulin. But ultimately, you are only giving two types of insulin. You're giving basically basal insulin and bolus insulin. Bolus insulin is they just theoretically classified into a nutritional insulin and a correctional insulin, but ultimately it is given as one thing only. And I hope this was making sense thus far. So then now we'll come back here. So coming to basal insulin again. So we basically said it is like total insulin dose is like zero point 0.5 unit per kg. So basal insulin is basically going to be around half of that. So if we have a 50 kg patient, it's going to be somewhere around 5 to 15 units to start with, and you're going to titrate this basal insulin according to your fasting glucose levels, and you target around 100 to 130 mg per deciliter. So how do you actually titrate this? You look at the fasting glucose. If it is less than 100, you actually decrease the dose, because that is too much control. You don't need that much control. 100 to 130, you are in the perfect range. You consider continue with whatever basal insulin you had given earlier. Now in increments of 30, so 130 to 160 you increase by 2, 160 to 190 you increase by 4, 190 to 220 you increase by 6, more than 220 you increase by 8. So this is how you increase your basal insulin. You don't have, even if you don't by heart this, it's okay, because you can always refer. But just remember the concept that basal insulin is going to be titrated according to your fasting glucose levels, and the target is around 100 to 130. Nutritional insulin is what we give with meals, so it will come to around 0.05 to 0.1 unit per kg per meal. So there was actually a basal plus trial where they had patients who were actually having mild diabetes controlled by diet or OHA or low dose of insulin. So they showed that if you o- om- o- uh, omit the meal-associated insulin correction, it still resulted in equivalent glycemic control with a reduced risk of hypoglycemia. This was in patients with mild diabetes. So in patients who are having full-blown uncontrolled blood sugar, this is not actually applicable. But in patients who are having very very mild diabetes, you can get away with not actually uh, adding the correctional insulin as well. So that is one thing. So correctional insulin is what you basically do as a sliding scale. This is very, very commonly misunderstood because people think there is one sliding scale that is going to be applicable for all patients, which is completely wrong. So you have to have different sliding scale, which are going to be as adjusted according to whether the patient is insulin sensitive or insulin resistant. Why is this? Because different patients will respond to insulin differently. For example, if patient A, has a blood sugar level of 350 in the afternoon, and you give the patient around 18 units of regular insulin sub-Q. And in the evening, if you see the patient's RBC is 290. Okay. Now, patient B with the same RBS level in the afternoon, you are giving the same dose of regular insulin. You look at his RBS levels at the night, and you find it's gone to 67. So insulin is not going to act in the same way for different types of patients. That is why you always need to adjust the type of scale you're using depending on your particular patient. So how do you decide whether to go for the insulin sensitive scale? That means insulin sensitive is basically increased risk of hypoglycemia. Patient is NPO, elderly patient, CKD patient, increased risk of hypoglycemia. Go for a more conservative scale. Insulin resistant scale, patients who are having no risk factors for hypoglycemia, on steroids, or having total daily insulin requirement more than 80 even before they actually came to the hospital. So those patients are going to be very, very difficult to actually control. So they will need to have a more aggressive scale. So this is the scales that are recommended. So you have a sensitive scale, usual scale, and a resistant scale. Again, it is very very easy. So if the pre-meal levels are 100 to 140, then you add zero. That means you don't. It doesn't mean that you're giving zero. You're adding zero to what you calculated per according to the patient's weight, which is 4. So if it is 140 to 180, it is plus 2. So you go here, you go every 40. So 180 to 220 plus 4 to 220 to 260 plus 6. 260 to 300 plus 8. And 300 to 350 plus 10, 350 to 400 plus 12, and more than 400 plus 14. This is for sensitive. So usual patients eat a little bit more than that. You had the whole scale increases by around plus 2 compared to the sensitive scale, and for the resistant patient, the whole scale increases by plus 2 compared to the usual scale. So this is basic funda about how sliding scale works, and you will understand why here that people actually misunderstand this, because they think that one scale will work for all patients, which is not true. Uh, different scales will have to be used for different kinds of patients. So I hope this is actually clear. So coming to making a basal bolus regimen, there are three scenarios where you're actually going to start a basal bolus regimen. One is patient is going to be transitioned from an IV infusion. For example, if patient was on an IV infusion for either severe uncontrolled blood sugars or DK or etc. Patient is having a known prior insulin dose that you have available, and you have good history and good documentation available to you that this was the dose that the patient was actually taking regularly before they actually came to the hospital. And the third option, which is what I had already described, which is based on the weight. Now, IV to sub-Q transition, going from IV infusion to sub-Q, you do not convert the whole thing into sub-Q. That is wrong. You take the total IV daily insulin requirement. So how do you calculate this? Basically, you look at the IV infusion dosage for around 6 hours, and you multiply that by four. You will get an estimate of the 24-hour IV insulin requirement, and you transition that to sub-Q by decreasing it a little bit. You take around zero point 0.6 or zero point 0.8 times that daily IV insulin dose. So you are actually taking only around 60 to 80% of the daily IV insulin dose to give sub-Q. Now, question is why? Why you are actually giving less amount sub-Q than you were giving it IV? Number one, when you were actually starting the infusion, patient was likely sicker. Patient is having probably more stress hyperglycemia during the start of the infusion than at the end of the infusion. Patient is probably on a better clinical trend, and probably is going to be having an increased risk of hypoglycemia as a result. Number two is that patients, some of the insulin might actually bind the plastic tubing and may never actually reach the patient. That is also a possibility. So this is why generally when you have the IV to sub-Q transition, you take a little bit lesser dose. You don't convert the entire IV dose to the sub-Q. So again, the split is similar. Once you calculate that TDD, you again again you have the 50-50 split. If the patient is NPO, you're giving the entire thing as basal. So you no bolus if the patient is not having any food intake. And if and the basal insulin has to be started at least 1 or 2 hours before the insulin infusion is stopped, because again IV insulin is very very short acting, and the patient is going to have rebound increase in sugar if you stop it too early. So what about using it on a prior insulin dose? You need a good history. You have to be careful here if the patient is having a huge amount of basal insulin, more than zero point 0.6 unit per kg per day. Why? Because if the patient is having a very, very large amount of basal insulin, that means that the patient's basal insulin is actually inappropriately acting like a premial insulin as well. So if the patient becomes impatient and the patient is suddenly not going to be eating that much, then this and huge basal insulin dose might actually be detrimental. That is why societies recommend that you decrease the basal insulin from your OPD prescription by around 10 to 20% on admission, especially if the patient's sugars are uncontrolled and HbA1c is more than 8%. So again, based on weight, we already told, I already told you this. I'm just re-emphasizing here. Risk factors for hypoglycemia, zero point 0.3 unit per kg, no risk factor, zero point 0.5 unit per kg per day. And is split it, basal bolus, and all of these were already described here. Now coming to a few specific scenarios, just as a bonus here. If what if the patients are on steroids? For example, patients have meningitis. Patient you started on Dex on some steroids, or you started steroid for some other indication, and patient is having hyperglycemia as a result. In most of these patients will not actually require insulin, number one. If they actually do have persistent hyperglycemia that actually makes you want to give something, this is where NPH actually is useful if the patient is taking prednisone as the steroid. So if the patient is taking prednisone, you to give zero point 0.4 units of NPH for every 1 milligram of prednisolone. If the patient didn't have diabetes beforehand, you divide that, reduce that dose by half. And if the patient is on NPO then we reduce that dose by half again. So again, this is extra, not very essential in the grand scheme of things. And just remember that this doesn't work for steroids other than prednisolone. And in those cases, they will actually need more than one dose of insulin to actually control the blood sugars. Now, all of the what I've told you is for inpatient glycemic control. That means patient had some indication to be actually inpatient. Patient was not asymptomatic. Patient maybe had cellulitis. Patient maybe had pneumonia. Patient was maybe on NIV, and the patient is having hyperglycemia, and the patient is being stuck in the ED for a while. Maybe the patient is being stuck for 2 to 3 days because the patient is not having getting inpatient beds. What this lecture is not meant to be for is for asymptomatic hyperglycemia in the ED. Patients having no symptoms and hyperglycemia, you don't actually need to reduce their blood sugar before you actually discharge them. Now, the evidence base for this is actually less than the evidence base for asymptomatic hypertension, but still, what we're normally afraid is if you discharge the patient and the patient comes back with DKA, and there's one study which actually showed that they looked at giving insulin in these kinds of patients, and they show that it doesn't actually reduce the rates of decay in the 1 week after discharge, and it simply just increases the risk of hypoglycemia, which is again bad, especially in patients who had no symptoms to actually begin with. So, asymptomatic hyperglycemia, you don't actually have to do anything. You can actually refer them for OPD management. So, what are the take-home messages from this talk? Overly aggressive glucose control is dangerous. Multiple studies have shown that it can lead to more harm. There is a good chance that it actually leads to increased mortality, at least in some sets of patients. Don't be very dogmatic about specific target, saying that it has to be less than 180, it has to be less than 190, it has to be less than 140, blah, blah, blah. So, because nobody is really sure what ultimately what the perfect strategy is. We just have information. We are just practicing based on the information we have right now at our disposal. Try to avoid unnecessary infusions as far as possible. Basal bolus regimen is the way to go in most patients. You don't need to actually start them on an infusion. Uh, be very careful about dosing patients in patients who are in NPO, because they can have very wicked hypoglycemia without warning, especially if you are giving them bolus insulin. And never withhold basal insulin in patients who are type 1 diabetics, because that is a great recipe to push them into DKA. These are the references that I used for this particular talk. And now we will stop here for questions.